So welcome. Clare Cortright is Policy Director with Cal Voices. And for those of you who aren't familiar with Cal Voices, they are a peer-run organization who improves the lives of residents in the diverse communities of California through education, advocacy, research, and culturally relevant services. I would put some other labels on Clare, including attorney, including legislative geek, and hero. Clare was too young to know when the 400,000 signatures were collected in 2004 to put Prop 63, the Millionaire Tax MHSA, Mental Health Services Act, on the California ballot. MHSA had built-in protections, which in 2023 and on the 2024 ballot measure will substantially alter it despite those protections. Clare has been in a fight to reduce harm, to educate the public. We'll hear from her tonight about what are the next steps we can take. She'll take us from the totally justified emotion to action. I do want to acknowledge that the League of Women Voters is a neutral organization, and we will have future educational events that will demonstrate the different points of view. And I welcome you all tonight, and wake me up. This is not 1970. Let's go from the medical model to the recovery model again if we need to. Take it away, Clare.
Wow, thanks so much, Jean. And I learned some awesome things I did not know about you. Thank you so much for having me. I understand you're a nonpartisan organization, and so we are in a strong opposed position to Prop 1, both to SB 326, which is the modernization of the MHSA, and also to AB 531, the bond, not because we don't like all of it, but because some of it we definitely don't like. So I try to, my presentation definitely presents a unique point of view, but I also try to keep it deeply rooted in facts and what the law says and what the history and the political history of this is. I will try to be brief. The MHSA is large. It has changed over time. It exists both in statute and in regulations, and how those have been changed by the actions of the legislature and the proposed ballot initiative are complicated. This also touches many other parts of the mental health system, as you will see. And so what I am presenting is necessarily overly simplified. But I didn't want to assume any familiarity on the part of anyone, because so many bills and so many laws come up before us. And so, I have struggled to be, simple and informative, but also accurate, and also represent, why we're in a no position on this. So I'm going to share screen and get started. Okay, is that fully visible to everyone? Okay, I'm getting a thumbs up from Jean. Let me get the participants off here because I don't have two screens, so you're going to see what I see. Okay, yeah, just to reiterate quickly, Cal Voices is the oldest peer-run organization in California. We've been around for 75 years. I am the policy director. Thank you so much, Jean, for the introduction. I am an attorney. I'm also a person with lived experience of serious mental illness. And the involuntary side of our public behavioral health system. I'm also a former MHSA client and a person whose life was absolutely saved and altered and changed and forever bettered by the MHSA and its genius and inclusiveness and accessibility. So I have strong feelings about it because it saved me when I didn't have Medi-Cal. Other than that, I'll introduce, so I mean, again, a little background on me. I spent a lot of time representing mental health consumers in the public mental health system who are fighting their involuntary hospitalizations or holds. I was also a mental health provider. So I've worked in every acute locked facility in Sacramento County, Santa Clara County, Yolo, San Joaquin, a couple of the county jails, and also in crisis residential and boarding cares, in 2 more counties, including Jeans County, which is San Mateo. So I've have a fairly unique and broad experience. So again, Cal Voices, we're the oldest peer-run organization. Peer-run means we're completely run by and for people with mental illness. Everyone who works here is either a family member or a person with lived experience of mental illness. What we do is we are a direct service provider. So we do peer support. We do a number of programs funded under the MHSA in Sacramento County and adjoining counties. We are official educators for peer support workers under the Medi-Cal certification under SB 803 for the state. We did that before it was a thing. We're some of the OGs on that in making a curriculum for peers to support peers and be providers. And we also do policy advocacy. In terms of mission, vision, values about Cal Voices, we're really trying to take mental health back to the original formulation of ethics in medicine, which is first do no harm. So in any place where we're saying that a disabled person needs to be harmed to be helped, we're trying to eliminate that and get to a place where everything we're doing is purely positive and there's no harm. We want to eliminate carceral responses to mental illness and carceral thinking. There's a lot of really good progressive thought going on in the community at large around disability justice, prison abolition, mass incarceration, and how we think differently and act differently with respect to vulnerable people and people in need. We would like to demand entitlements to voluntary recovery-oriented services and a social safety net, which don't exist for our community, and hate, stigma, ableism, negative stereotyping, and systemic discrimination, and stand for the principle of nothing about us without us. Many, many things in policy happen without us being involved, without us being considered worthy to speak on the subject or experts on the subject, although we are. For the agenda today, I'd like to contextualize the issues in policy, talk about the history of the MHSA and basic components of the MHSA, how SB 326 changes the MHSA, AB 531 the bond, how those two things relate since they are being packaged as Prop 1, and kind of what else is going on in the ecosystem of mental health at this time. And I'm realizing this might not be my most updated PowerPoint, but we'll roll with it because it's up. Okay, so to contextualize the issue, obviously all of this focus on mental health went from a relative policy backwater to kind of the Big Ten, right? Everyone's talking about homelessness and mental illness. So I thought throughout this presentation, because the MHSA is county specific and I'm in Sacramento County, that I would highlight Sacramento County throughout in these issues to kind of contextualize and bring them down from the sort of high level more into the community. So this is from Cal Matters. And this is a chart of California homelessness over the last about 16 years. So you can see, even going back to 2007, we had 140,000 unhoused people on the streets of California. You can see that dipped and then began to increase again, around late 2018, 2019, and then sort of exploded over the pandemic to where we are now. But homelessness in California is really not a new issue, and having extraordinary numbers of unhoused people on our streets is not new for the state. During COVID, we know what happened, or if you're familiar with the issue, you know what happened. We're looking at a much higher number, about 22,000 more people unhoused in the state of California from about the beginning of the pandemic. I think the first case of COVID was January 2020 to present. So we did see an explosion of homelessness over that period of time. And then taking it into the local community. I'm sorry, can you guys also see my dialog box up here that's blocking the slides, or can you see the full slide, Jean?
Full slide.
Okay, great, because I have a different view. I just want to make sure you can see it. So this is just federally available. This is from the Federal Reserve. They track local conditions, and you can kind of see towards the left end of the slide what happened, you know, around the beginning of the pandemic. You see what we're all familiar with and living with, which is the median home price, including in local communities, like takes off, right? And the prior most expensive housing in California is around 2005. You can see that previous dip. That's the the housing bubble and the Great Recession, and we're well beyond it now, which we are all living and feeling. And so, you know, for the Sacramento area, and I really felt this because I was here before the pandemic and then came back and saw the difference, you know, rents followed suit, right? So we had this explosion in home prices off the backs of super low interest rates and a bunch of $1.4 trillion in 24 months pumped into home lending, you know, on the fear that COVID was going to take out the housing market. But instead, what happened is we saw this explosion in price. And so this is what happened locally in Sacramento. You know, you saw rents from 2018, they were around $1,200 was the average rent. And at the height of the pandemic, you know, it was almost $1,700. So that's like a 39% increase in rent in, you know, less than 5 years. And over the pandemic, it was a 24% increase in rent. So there was just this, there's a costs are going up, and those aren't the only costs that are going up. You know, over the same period of time in this community, in my community, you know, that the median household income, like median means the middle, right? Like there's half of people make more, half of people make less, right? You've got rents going up 39% over 5 years, 24% over 24 months. And over that same period from 2020, you see that gray bar, the household income only went up $10,000. So people are getting left behind. And if you are the median household making $80,000, that means everybody that lives there. We also have super high density. We have lots of low wage workers all trying to live together to make it. So household income is really just doesn't matter if you're related, it's everybody that's in the house. So, you know, you see household income, you know, going up marginally compared to rents going up massively. And it's not just housing, right? Like, I think people don't really realize the cumulative effect that everybody's dealing with inflation. And again, over, you know, the pandemic to present, the cumulative consumer price index of all things going up, it's 19%. This is like pretty difficult for people to deal with. And then particularly in California, and I'll come back to this because we have beef over it, is over the same period of time, you know, from the beginning of the pandemic to present, we see that super wealthy Californians, the 1%, these are the people who pay the millionaire's tax. These are the people who are on the hook for the 1% MHSA tax. They are funding our MHSA. Their incomes, right, not their real estate, not their stocks, they're just income, their cash income went up 7.5% over the pandemic. And I think people need to ask the question policy wise, you know, is this the natural functioning of a free market, or is this the cumulative effect of government policy? But part of the context here for the MHSA is that the state now wants the counties to cover substance use services for people that don't have a mental illness, which is not something the MHSA covered previously. So there is an unknown, very large population of people that the state is asking counties to provide services for without additional funding. There was a very real attempt within the legislature and amongst advocates to get the administration to raise the MHSA tax on this population because of inadequate funding for additional services. You know, the most modest attempt was 0.25%, and that was refused. And, you know, if you are a person who was, you know, if you look at the legislative analyst's office or you know about this issue, you know that most of the funding for the MHSA is coming from people with incomes, personal cash incomes, not stock options, not anything else, over $5 million. And over the pandemic, they would have seen their incomes go up to $5,375,000 from $5 million. And their increased MHSA tax, had they been assessed for 0.25% would have been $17,000. everyone said no. Um, take what you will from that. And so again, you've got all this going on in the housing market. You've got inflation, home prices, the median home price in Sacramento over that 24 months of the pandemic went up $185,000. Rents went up 24%, inflation's through the roof. And so what happens, right? What happens in Sacramento County? Between 2019 and February of 2022, they did a point in time count. That's where volunteers go out and they try to count all the unhoused people on a single two nights. This is how the federal government does it. And what they found is that over this period of time where wealth inequality was exploding, where housing and rents were exploding, Sacramento's homeless population doubled. And then, so also part of the debate is who are the unhoused? Who are the people that we are talking about? Fortunately, UCSF Benioff Homeless and Housing Initiative, which is a leading voice for Housing First, a leading voice for making sure people don't fall into housing, into homelessness currently, did a study that they released in June. This is the largest study of the unhoused population since the mid-90s, so almost 30 years. We're looking at a population that is now 173,000 unhoused people. When they tried to say, what's the leading cause? What's really causing people to fall into homelessness? It is what you would expect. It's low incomes, high rent, and a sudden loss of income, which happened to a lot of people through COVID. A lot of businesses closed. A lot of people lost their jobs and never got new ones. It also busted some myths, right? Like, where are the unhoused really just coming here for the good weather from out of state? No. The unhoused in California are overwhelmingly people who are from California, previously housed in California. 39%. And again, this is based on survey data and you're projecting it onto a whole population. So everything's a little bit guesstimate-y, but it's the best study that we have and the best information that we have about who's unhoused. So you've got 39% of people who are experiencing their first period of homelessness. So we've got new homeless. Unfortunately, 78% of the people who are unhoused are completely unsheltered. They don't have anywhere to stay. They're staying outside there in your encampments. They're in their vehicles. So everybody wants to know, how much of this population is seriously mentally ill? What percentage of this population has serious substance use disorder? What are the contributions of those two struggles to homelessness or the relationship? And it's not as dramatic, I think, as it is made out to be. They didn't use a simple questionnaire of, do you have a diagnosis? They wanted to use the broadest measure possible. So they asked, okay, in the prior 6 months, how many of you went to a mental hospital? It's 5%. It's 8,500 people out of 173,000 people. That's not a huge statistic. If you're really fluidly psychotic on the streets, my experience working in the hospitals, you end up in the hospital, you end up in jail. It's just not showing up in the numbers that the people who are, the overwhelming population we're talking about are seriously mentally ill. They used another measure, lifetime history. So, in the prior 6 months, how many of you went to a mental hospital? 5%. In terms of a lifetime history, have you ever been in a mental hospital? 27%. And interestingly, 56% of the people who had been in a mental hospital, the mental hospital was the first stop before they became unhoused, which is a real concern for me as an advocate. What I spent a lot of my time, I was physically in hospitals defending folks, but what I spent a lot of time doing was just advocacy, because the number one concern of every single client is I'm going to lose my job because they get picked up off a street with no notice. They take your cell phone. You don't have any phone numbers. You don't show up to work and you lose your job. And even folks who have serious mental illness, a lot of them do have employment, either full-time, part-time, and it is important to their lives. And the hospitalization can mean losing their job, which they lose their income and they lose their housing. So that really stood out to me, that we should really be talking about that. Like, what's the contribution of interventions that are highly disruptive to people's lives in homelessness? That's very important. And I was surprised to see that there. Also, in the prior 6 months, if you want another measure, what percentage of the population experienced psychosis from any cause, right? Because methamphetamine in particular can cause psychosis, 12%. We're not looking at super high numbers of the unhoused who have substance use necessarily present or causally related to their homelessness. Also, the folks on the street are older. The median age, meaning half people are younger, half of the people are older is 47, but 44% of the people are over 50. We have a crisis of seniors whose fixed incomes can't keep up with any of this, and they're ending up on the streets. And then also contributing to, the picture of who's unhoused in California, and the homeless study does talk about this too. It's folks with fixed incomes, low income, no income, or benefits. And, I think people don't realize this. There is almost no social safety net for permanently disabled people in the United States, not in the state of California, not nationally. In order to get California state disability insurance, you have to have a significant work history. You get 60 to 70% of your earnings, and it terminates at 52 weeks. So if you can do the math on that, it's not long. The only option, if you're permanently disabled, is out of the federal system, is Social Security supplemental income if you have no work history, or you're not yet retirement age and impoverished, or Social Security disability income if you have a significant work history. Most of the clients I've ever served, because their mental illness occurred younger in life, they have disrupted educations, they have disrupted work histories, they can only get SSI. The maximum benefit is $914 a month. In some instances, the state will kick in a supplement that caps out at $219 a month. And in California, there is no entitlement for these permanently disabled folks who can't provide for themselves through no fault of their own. There is no housing entitlement. And SB 326 doesn't do it. AB 531 doesn't do it. No Place Like Home doesn't do it. There is no program that entitles a disabled person who can't work to housing, and there is no source of funding to comprehensively house these people. So, as a provider who was serving a lot of folks in the Medi-Cal system coming out of acute hospitalization in one of the richest counties on the globe, these people are unhoused and they have no options. Any questions on any of that context before we begin?
So it looks like we have one question here in the wings.
Okay.
So if Prop 1 diverts money from traditional mental health programs to housing, and homelessness in Sacramento is caused by a disproportion between rent and income, wouldn't Prop 1 help with homelessness by building housing? It has some $922 million for supportive housing for people with serious mental illness and substance use problems.
Great question. Complicated answer, right? Because 326 has some quote unquote housing interventions money in it, but it's a slush fund. It's not a housing entitlement. None of these things are housing bills, right? I mean, that's number one. Does either one of these bills create an entitlement to housing for people that cannot provide themselves housing? No, it does not. Does Prop 1 include some money, the $922 million, for folks with behavioral health issues, for permanent supportive housing? Yes, it does. It also contains some other things. So $922 million is a broad eligibility for folks with behavioral health conditions. $4.34 billion is for the Behavioral Health Continuum Infrastructure Program, and that's like unlimited for locked facilities. So it's kind of a poison pill in our perspective. Also, we should probably talk about No Place Like Home, which was $2 billion in 2018, partially funded through MHSA. Not a lot's been built and not a lot of people are housed. So, you have to consider that too. Like when the way that you want to house people is through building additional infrastructure, that's an incredibly lengthy and uncertain process. But I'll leave it there. Okay. I will go on to Prop 1, which is the Mental Health Services Act, Prop 63 from 2004. I may actually have to switch out my presentation if I got the wrong one and it's not the most updated. Okay, so just a background. What is the Mental Health Services Act? It was a grassroots ballot initiative. What that means is there's different ways to get something on the ballot in California, as people are aware. If it needs to go on the ballot or should go on the ballot, it can go on the ballot through the legislature, where they pass a bill and they put it on the ballot and they sponsor it, essentially. The other way to get something on the ballot in California, thanks to our wonderful Constitution, is called a voter initiative. And that's where you go out and you say, hey, the voters, and the people, the voters, they want to make law directly. They want to go around the legislature because the legislature is not getting it done. You can do that in California. You can do a wide variety of things through the ballot initiative process in California. So the Mental Health Services Act was a grassroots voter initiative, which means, in fact, and probably Jean was around and she knows more than I do. I've had to learn the history because I was quite young. But the MHSA was, it had two scribes. I won't say they are authors. It had two scribes, Rusty Seelix from the Mental Health Association, and Daryl Steinberg, who's currently the mayor of Sacramento and at the time was in the California Assembly. And the MHSA was building on some other kind of different ideas in mental health, but this was a grassroots initiative. So this was literally written by the community. Rusty and Steinberg did do the hard work of drafting something into a legislative form, which is like something I do, like you have an idea, but then you have to make it lawyerly. So they did that, but this was built with the community. This was built over an extended period of time with multiple stakeholder meetings, multiple amendments. I mean, there's tons and tons of different versions of this. We have all the history here because there's a lot of folks who were involved. So this was a lot of people's ideas coming together and being refined in a community process. And then ultimately, when the ballot initiative was written, it was really the labor of disabled people and advocates. They had to collect, to qualify for the ballot in 2004, you had to have more than 373,816 signatures, and disabled people did that on their weekends outside the Safeway with their kids in tow. And what the MHSA did was it levied a 1% tax on personal incomes over $1 million to fund mental health services in the public behavioral health system. So this is going to be services through the county. It's not private insurance. And part of the fundamental idea of it was insurance isn't good enough, right? Medi-Cal's idea of what I need, how much and when, what mental wellness is, what services I need as a disabled person with a unique illness. It's not holistic enough. It's not expansive enough. It's not enough. Medi-Cal isn't cutting it for us. And so we want a source of funding that is not tied to insurance, that you don't need insurance for, and that will fund things that are progressive and community driven outside of the insurance model. So these are some of the quotes. This is some of the original intent here. It was born from a recognition that, this idea that anybody with a serious mental illness needs is a psychiatrist, if you're lucky, a therapist, and medications. No, that is not the case. And so since that's the only thing that the sort of traditional, what we call the medical model provides, and Medi-Cal provides, we were looking outside of it. The community was looking outside of it, and they were looking for a way to provide services, before you end up in the most dire of circumstances where people start to offer you things. So really, they talked about going from a fail first system to a help first system, and that was the concept of MHSA. Again, the intent was to transform the current system into one in which there's partnerships between clients and families and the communities. And the input is from bottom up, right? It's from people with lived experience. It's from the community. It's from the unique demographics of the community and the unique needs of the community. You know, and again, I mean, this is really, I highlight this because this is the exact opposite of what's happening now. You know, it would require different activities and services that are not currently funded through Medi-Cal or other private or public insurance payers, and include people who aren't covered by insurance. So it's interesting that you brought up single payer, because like part of the picture here is that MHSA is one of the gap fillers, right? You don't have to have Medi-Cal to get MHSA services. So obviously, like, Medi-Cal doesn't cover everyone. We still have many, many, many uninsured and poor and mentally ill people in the state of California. And one of the ways that they can get services without insurance is the MHSA. And that is being flipped on its head. Everything is being put in service of Medi-Cal. So, you know, one of the ways that MHSA was super equitable is, you know, you could be undocumented and not qualify for Medi-Cal and get specialty mental health services through MHSA. So who does the MHSA serve currently? It's called the target population. We're looking at seriously emotionally disturbed children or adolescents under the age of 18. There's bells and whistles and definitions for that. It involves functional impairments and certain risks. Very similar. We're looking at adults and older adults with a serious mental disorder or who are dual diagnosed, but not standalone, not substance use only, dual diagnosed. And there's some bells and whistles on that for, you know, functional impairments and risks. We're also looking at adults and older adults who are at risk of ending up in acute ends of the system, or who have certain symptoms. And then within specific programs, there's a lot of equity-focused requirements that came from the community and got put into the MHSA because it has changed over time. And so there's really a focus on unserved, underserved, or inappropriately served populations, tribes, racial and ethnic minorities, religious and cultural minorities, LGBTQ, criminal injustice involved people, you know, immigration populations, people that don't speak English as a primary language or they have low English proficiency, and the uninsured, etc. So it's a real equity focus of the MHSA. And then the MHSA had general standards. Everything you do under the MHSA is supposed to adhere to certain principles. Community collaboration, and that was primarily through what's called the community planning process, because all the budgeting and planning of MHSA funds is supposed to come through the local community, be approved by the local community, and really be responsive and flexible to local needs. So community collaboration is one of the primaries. Cultural competence, recognizing that we are not all the same. This is a highly diverse community, and to serve them appropriately requires diversity. That it was client-driven, family-driven, wellness, recovery, and resilience focused. And that MHSA services be designed for voluntary participation. How strict of a bar that is legally after time. Is there anything involuntary in the MHSA? There is, but it is very diminished. It's very de minimis because there's various regulations that limit it. And then there was just a culture of not funding those things through the community planning process. So if you look at, you know, sort of currently what's the status of MHSA funds flowing to something involuntary, almost nothing. And then there are certain restrictions, right? No standalone SUD services, non-supplantation, which meant you can't steal these funds and use them for something else. Everything you're spending under the MHSA has to be approved. No incarceration or law enforcement involved with this money. And also some broad regulations against using it for involuntary purposes. So what are some of the basics of the MHSA? So you kind of have this sense of what we're, you know, who we are serving. And then, so all this tax money comes in and the state collects it. And of that tax money currently, 5% goes to administrative costs for the state. The other 95% must be distributed to California's 58 counties to spend in accordance with the MHSA. So how much revenue are we talking about? A lot. I mean, that's one of the things is, I think throughout this kind of, this is from the Legislative Analyst's Office. One of the things that has come up during this conversation about SB 326 is, the MHSA is kind of a sideshow. It's sort of icing on the cake of the public behavioral health system, and it's not. It's actually a third of the public behavioral health system. The average tax revenues go up and down, but the average amount of money that we're talking about on an annual basis from MHSA tax revenues around $2 billion. So this is not a sideshow. This is this is a deep source of funding for our mental health services. And then currently under the MHSA, this 95% of tax revenue that goes to counties has to go into 3 buckets, and they're called prevention and early intervention, innovative programs, and community services and supports. These programs have broad definitions about how money can be spent, but what specific programs are funded is really up to the counties. There's a lot of flexibility. So if we break it down a little further, currently under the MHSA, how those buckets are broken out further under community services and supports, half of it has to be spent on full service partnerships. That is a case management style. It's called Whatever It Takes. It involves a broader array of assistance to people, including things like, money for clothing and assistance getting a job. And housing particularly is you're more likely to come by it under an FSP in the MHSA currently. Then we have the innovations, prevention and early intervention. Currently, half that money has to be spent on folks who are under 25. So we have our, roughly speaking, transition age youth. Also under community supports and services is the community planning process, where the community is actually involved in budgeting and spending and planning and all of the MHSA money, and that's mandatory spending. Other things you can do under CSS include what's called general service delivery, outreach and engagement, capital facilities, technology, workforce, and having some money in the bank for a rainy day, prudent reserves. So there's a lot going on in the MHSA, but all I want you to take from this is that there's a lot of flexibility to the counties. The regulations on how you can spend money currently are quite broad. Here's a little bit of a deeper dive. I will let you read this at your leisure about what prevention and early intervention means, what kind of programs we're funding under it. And then, I said I would try to bring it down from the sky. So, we're spending 19% of our MHSA funds on prevention and early intervention. So what does that mean in Sac County? I looked at the Sac County plan. What is MHSA prevention and early interventions funding under in Sac County? A lot, right? This is a lot of money, $20 million over a 3-year plan. And this is almost 65,000 calls to a specialized suicide prevention hotline. This is a lot of outreach. This strengthening families programs, there's things that includes that, I learned about for the first time. And I was like, wow, that's terrific. Like one of the things that's being funded is families that have chosen to adopt a child with complex behavioral health need. There is respite care for that family. There are summer camps for the kids. There is support for the family that has chosen to love a child with that kind of need. And that's the kind of thing that MHSA is funding that Medi-Cal will never fund. So, to just give you a sense of what this is on the ground and why it's special. This is a lot of voluntary services to a lot of people. And here's an example, of the community planning process in action. Something the community requested and was approved and was funded through MHSA was a trauma-informed wellness for the African-American community. Sorry, Medi-Cal's not going to do that, folks. Innovative programs, here's kind of a deeper dive on what that means. The idea of innovative programs is that we're dedicating funding to keep progressing in how we do better to serve underserved folks, improve the quality of services and outcomes, and keep moving forward with mental health, and recognize that we should never be at a place of stasis where we think that we've solved it, when we still have a lot of need, and outcomes aren't what they should be. So that's what innovation funds are for. In Sacramento County, how are innovation funds being used? The Mental Health Crisis Urgent Care Clinic, which is a voluntary walk-in alternative to an emergency room, where you can immediately meet with psychiatrists, nurses, clinicians, peers. It's access to medications. Even my lawyer friends who had a gap in insurance and were running out of medications in Sacramento, everybody knows you can go to the urgent care center and you can get access to medications immediately, which you cannot do through an ER. You don't need any insurance. The services are rendered regardless of ability to pay. Nope, this is funded through MHSA innovation dollars. So community services and supports and other expenditures. So this is the biggest bucket, the CSS bucket. All kinds of things are funded through this. We've got full service partnerships, which came up through innovative programs and pilot projects. And it's kind of, I could summarize it as we're trying harder, right? Because the broader array of services, the greater intensity of interaction with the client, they're recognized as a very successful. So full service partnerships came up as an innovation. They're now the majority of CSS funding. You can also do general system development, which includes wellness centers, peer support, all kinds of great stuff, outreach and engagement. And there are some other things that you can do out of CSS as well. I'll let you browse who can be in an FSP. Again, the general systems development component of CSS, you're looking at all kinds of stuff. Mental health treatment. This is the core mental health treatment funding, right? So we're talking about outpatient treatment. This is where it's coming from. We're talking about peer support, culturally specific treatments, wellness centers, crisis intervention. Many things are coming out of here. And again, you will see all throughout MHSA a focus on reducing ethnic and racial disparities. Real commitment to that. So again, I'm going to breeze through the more detail on what outreach and engagement means, workforce, education, and prudent reserves funding under CSS, and kind of get down again, because people want to know, what are we talking about? What's going to get cut? So this is CSS for Sacramento County. This is one example. This is from their MHSA plan. So this is what CSS is funding. It's a lot of money. And this is what it's funding every year in Sacramento. You've got 60 crisis residential beds. I worked in a crisis residential. That's a terrific program. That's for folks coming out of hospitalization who need a longer time before they move on to what's next. We've got wellness centers, we've got peer partners, respites, we've got a variety of full service partnerships. There's a lot going on that is funded through CSS. Also, again, I've mentioned I cannot do it justice in this PowerPoint, but there's also, core to the MHSA is the community planning process. We're not supposed to be spending any money, choosing what programs to fund, choosing what programs to continue. There is a mandatory process to engage stakeholders at the county level and come up with the plans for how you're going to spend this MHSA money. And the funding to engage the community and make that happen is actually in the MHSA. There's funding to educate the community to be able to be involved. It took stakeholder involvement very seriously. So I'm going to skip this because I'm running short on time, more on the community planning process. Also, I will spend a moment on this because I think it's important, and it comes up, and it's this question, right? What does housing mean? It's in the bond, it's in 326. So I want to spend just a moment talking about what housing means in the MHSA currently. Housing means physical infrastructure. It means permanent supportive housing, explicitly defined, buying, building, or rehabilitating housing units, leasing, costs associated with financing and operating or maintaining buildings. It also means rent vouchers. You know, if you've worked with a county Medi-Cal client, they're like, I just got to get me one of these rent vouchers. You're like, from whence do the rent vouchers come that are not Section 8? They come from the MHSA. So there is the ability, any CSS funds, any county can use any CSS funds for rental assistance to house people, vouchers, security deposits, utility deposits, the whole shebang. Everybody in the MHSA target population is eligible for housing currently under MHSA, and any CSS dollars can be used to fund that. There's other housing adjacent stuff in there. And then, you know, prohibitions, right? Because there is, especially with this administration, a confusion or a mixing together of clinical treatment facilities and housing. They are not the same thing. I don't refer to my home as a clinical treatment facility because it's not time limited. The purpose is to house me, not to patch me up and get me to some level of what you think is functional. Right. These are different things. And there is a lot elision and confusion of these terms. And I just want to emphasize that the MHSA doesn't do that, right? To the extent that, you know, there is the general, it has to be designed for voluntary participation. It can be used if there's no other payer for a short-term hospitalization, but not long-term hospitalization or institutionalized care. There is a very broad regulation, arguably covers all MHSA funds prohibiting that. So housing mostly means housing in the MHSA. Okay. I'm actually fairly sure I don't have up the proper PowerPoint. Can I take a break for 1 second and pull up the one that is with my most recent? I'm going to stop share for 1 minute and grab it.
There have been some questions in the Q&A.
Yeah, I've already gone. I'm in excess of time. So while I make sure that I have the correct, the more updated PowerPoint, why don't you ask me the questions and I will answer them.
Well, one of them has to do whether your particular organization has budget that comes from MHSA funds, and I'd like to answer that from me, which and I, of course, am on an MHSA commission, and so we attempt through community input to find out what is important to community members and provide the services that they're asking for. And in my county, it turns out about 16% of the services provided in the county under behavioral health come from MHSA. And the balance of it comes from other sources. And so that means that BHRS can't actually provide all those services. So they contract with organizations. Some of the organizations in community in San Mateo County are peer-run organizations such as Heart and Soul, California Clubhouse. I believe we even have a contract with Cal Voices for things like peer certification training. And so, of course, peer-run organizations can bid on those contracts and provide those services under the county, and the money does come through MHSA. So it's nothing, it's not like that's a bad thing. That's a way to get where you want to. There was another question about which we haven't come to yet, is I think we should save it until later in the presentation, and that is, are there ceilings on what money can be spent for in different departments, such as crisis residential treatment or other kinds of things? Are there any limits in Prop 1? And there are a few comments that aren't actually questions about a dichotomy that runs through this whole thing about how do you provide humane services for people who have anosognosia, that don't recognize they are ill. That's the $1 million question. And I'm not sure MHSA or BHSA have a solution to that. But
Yeah,
I will let you
awesome.
respond.
Well, I have fixed my technical issue, and I will grab the proper PowerPoint. And I will ad lib while we do that. Yes. So because MHSA it funds such an incredible variety. Can you see my screen again?
Yes.
Okay, great. All right. We're cooking with fire. Yes. So like, what MHSA funds is a lot of community-based organizations, right? So yeah, it's faith-based organizations that are delivering services through their expertise to a particular population. It's LGBTQ. I mean, it's super diverse, right? The county is not going to do that. The county contracts most of the county contracts for a great deal of its services with community-based organizations. It's always been that way. It was designed to be that way. And then in terms of, so I will skip back, and I need to probably move a lot faster. But I will say, so how do you better serve people with anosognosia? First, you need to get rid of the stereotype that psychosis is a completely all-consuming 24/7 experience that eliminates your ability to think or reason. That's a totally negative, false stereotype. That's not my experience. So psychosis, that's, not my partner who has schizophrenia's experience of psychosis, and it's not the experience of psychosis when I've worked with clients around anosognosia. And although this is a central thesis, right? It's a theory. We don't actually have brain damage. That's not true, right? It's an analogy to stroke victims. But how do you deal with anosognosia? Well, first you need to start telling clients about it, because I've dealt with people who've been in the system for 30 years, and I'm the first person to tell them this term or the theory about it or what's happening, or that their provider thinks that they have it. So, I think there's huge improvements to be had in communicating with mental health consumers, about their experience of psychosis. And, I mean, raise your hand if you're in the room other than me and you've had a serious conversation with someone about, like, what's true, what's real, and how do you know? If you start centering mental health consumers and lived experience and people who have the expertise in what psychosis is like and the insight, right? It's actually the system that lacks insight. Like, if you start listening to people and trying to incorporate their understanding, you will get somewhere. Right. But you have to let go of this stereotype that there, that there's people that are sort of unreachable due to psychosis. Like, that's it's really ignorant. It's just not true. And anybody who's been around and experienced it themselves and been a provider, knows that is that the idea that psychosis is this all-encompassing and experience, and you can't communicate with anyone, and you can't collaborate with anyone, and you can't think through anything, and they aren't aware that other people think that they're psychotic. It's all just very overblown, in my opinion. Okay, moving on. So again, who does the MHSA currently serve? It's the target population. It's defined in the Welfare and Institutions Code. It's seriously emotionally disturbed children and adolescents, adults. We've talked about what that is. And then again, within specific categories, heavily equity focused on reducing disparities, right? All of these populations are specifically called out as people we're trying to serve and better serve, learn from. Yes, use community-based organizations, because the county can't do what a tribe can do. So what does the MHSA fund? We talked a little bit about that. It's community services and supports, which include 4 service areas: full service partnerships, which is a case management style; general systems development, which includes the core mental health outpatient treatment, peer support, wellness centers, etc., outreach and engagement; food, clothing, and shelter, outreach to orgs and individuals; and housing, overwhelmingly true housing. Prevention and early intervention, which is about, helping folks, public education and early intervention, helping people recognize the early signs, especially of serious mental illness, and intervene prior to the development of that further, or consequences of it further. So these are really beloved programs. They try to address mental illness in its early emergence and promote recovery and understanding. Prevent suicide is a big thing PEI does. Stigma and discrimination reduction, access and linkage to services, innovative projects. We've kind of touched on that they're about new approaches. We talked about this, talked about that, general standards, funding allocations. We talked about it's a lot of money. Talked about PEI in Sacramento, GSD, what it's funding in Sacramento, why it's special. So let's go on to 326, and I will zoom, and this is very abbreviated. So first, why are we doing this, right? Why did the bill's author, it's Susan Eggman, who is also a co-author on the bond and the author of Senate Bill 43. Which is related to all of this. So why are we doing this, according to the author? And this is all the analysis says, that it's time to update an old law. Okay. We want to prioritize certain at-risk populations. The MHSA prioritizes all kinds of at-risk populations. So this actually ends up being a gross oversimplification. It's really about the unhoused. We want outcome and accountability. There are outcome and accountability measures, but they are local. And so this moves outcome and accountability measures to the state from a top-down approach. It also says that SB 326 is to be paired with the bond, AB 531. We'll talk about that in a minute. And again, this is very minimal, right? We want to review where the MHSA has succeeded and improve it. Okay, very, very simple statement. And again, because this was a spot bill introduced after the bill had made its way entirely through the Senate, this was the first and only health-focused committee to hear this bill. And this is the analysis from the staffers. This is quotes from the staff of the Assembly Health Committee. This is their official bill analysis of 326, which was for the 8/22/23 hearing. There were some amendments afterwards. They weren't substantive. So I'm going to continue to quote the staffers on this. What else did the administration say they want to do? I've changed the name. Okay, that's a throwaway. Broaden the target population to include those with debilitating SUD. Update the local funding categories. What does that mean? Means 4% of the funding is taking away from the counties. Prevention and early intervention is gone as a thing. Prevention is now delegated to the state, and it means population-based prevention, which means no services to individuals. It means broad educational campaigns, what it sounds like. So PEI was really gutted in that way, in that prevention was really taken away from the counties and given to the state, and funding given to the state that used to go to the counties. They also dedicated 3% off the top of the MHSA funds. So this 4% for population-based preventions off the top, the 3% for workforce is off the top to the state. They also say focus on the most vulnerable and most at risk. The MHSA already does that in various ways. Transform the county planning process. So the MHSA planning process is now to be embedded in a planning process that includes all behavioral health services funds from all sources for the county. Could be a good thing. We don't hate everything in here, but that is one of its primary purposes. And improve transparency and accountability for behavioral health funding and outcomes. Again, that's really about reporting and top-down measures from the state.
Excuse me, Claire.
Yeah.
We have it's 8:21, and we have a few questions that I'm not sure we can get to all, but can you wrap it up in about 6 minutes?
Yeah, I'm going to go super fast. So if we can hold the questions, I will go really fast.
Okay.
Okay.
The basics.
All right, sorry.
No, that's
I
okay.
should have signed it. So what is it doing? It keeps the MHSA target population. It expands it to include people with substance use only, not just mental health. There was a big fight about this. Previously, the counties were mandated to cover substance use services under the first version of the bill. The county said, you're not giving us money to do that. It came back with an amendment that the counties can use MHSA funds to fund services, but they don't have to. So we are still broadening the population. It creates a bunch of mandatory priorities across programs for persons who are to be prioritized, and it gets rid of all of the equity language of the MHSA. So again, here's how the funding shifts. Prevention is gone. It's given to the state. Under CSS, everything is kind of getting shoved now. So early intervention, outreach and engagement, innovation, all of the outpatient services, all SUD services, FSPs, the case management is getting 35%. Housing interventions is getting 30%. But that includes not just true housing, but clinical treatment, both voluntary and involuntary. There's reasons why it will flow towards the voluntary end of the system, because the counties have a source of funding to pay for those things, and the court is involved telling the counties they have to. The state is now taking over population-based prevention, workforce, and administrative costs. What ended up happening is instead of the counties getting 95% of MHSA tax revenues, they're getting 90%. It went down, 10% is dedicated to the state. This is the new funding allocations, and there's a bunch of restrictions within these funding allocations that's different from MHSA. So even though 30% is going to housing interventions, half of that money has to go to the chronically unhoused with a focus on encampments. Similarly, everything, all those services that I talked about, PEI, CSS, everything Sac County is doing, all of it's getting shoved into the behavioral health services and supports bucket, and then half of that is restricted for early intervention. Half of that is restricted for early intervention under 25. Everything else that we're trying to do is supposed to come out of that this BHSS all other bucket. So you're looking at massive cuts. So this is the legislative analyst's office talking about it. You can go through the slide deck and look at that in more detail. Here's where I broke it out for you, right? So what's happening aggregate across all counties, full service. What the LAO did was look at every county plan, because you have so much flexibility and options. They went, looked at every county plan, added up what everybody's spending on everything, and kind of said, here's how things will shift. So currently counties are spending on FSPs about $515 million a year. They have to increase that spending by $221 million in aggregate to meet the new floor ceiling allocations of BHSA. Housing interventions, counties are currently spending $226 million, and it has to go up by about $500 million a year to meet the floor ceiling requirements of BHSA. Again, it's not real housing. And then, so what really, right, this is the part that everyone's up in arms about. CSS, all the services, early intervention, everything, all the programs I highlighted for Sac County, that's what's getting cut drastically. That, in a $2 billion annual allocation, CSS is going from $1.34 billion down to $621 million, $719 million per year being cut out of mental health services, basic mental health services. This is the Assembly Health Committee showing you the allocation shifts. There's really no justification for this. I really don't have time to go through all the slides, but it's just a bunch of quotes from everybody that's looked at this bill. The LAO saying there's no justification for this. You haven't said why it's okay to cut services to all these people to prioritize these other things, or why you wouldn't raise the MHSA tax so there's enough money to serve everybody and not do pecking orders and priorities, etc. It's pretty scathing, honestly. I just pulled, this is all from July. These were all the criticisms of the initial nonpartisan legislative analyst's office take on MHSA. Here's where you kind of add up how all that lack of flexibility goes away at the county level through a bunch of different provisions in BHSA, not just the new allocations, but changes to the target population, changes to outcome measures that you have to conform to, or you get sanctions. Even within discretionary spending, there's mandatory spending, and then also the involvement of the courts. So when you total up the picture, what LAO is saying and what the staffers on the health committee are saying, what a lot of people are saying is there's no discretion left in the MHSA. Whatever this is going to be is from the state. Community planning process is gone because that's a discretionary budget. You're not presiding over any budget. So again, the CPP, it remains, but it's kind of window dressing because there's no discretionary budget. So it's really a gutting and a top down, and you will see LAO say that. The health committee did an 85-page analysis. There's no analysis in it. The first 46 pages are summaries of the bill. There's some short summaries of prevalence. There's an MHSA audit. This is a long-standing fight. The counties were supposed to give the state back money they didn't spend. It was in the law that they had to do it. Nobody ever implemented it. They blame the county for sitting on unspent funds, but this had nothing to do with the MHSA not being effective or not being what the community wanted. And the balance of the analysis is stakeholder objections and repeated observations from staffers that the administration hasn't answered them. So there's no analysis, like where has the MHSA succeeded and where can it be improved? That's nowhere here. No one has addressed this. How or why, prioritizing unhoused people will improve the MHSA? Who gets deprioritized? Why is the loss of services acceptable? Why did the administration refuse to raise the tax? Why is there no needs assessment about the SUD population we're supposed to be serving? Why does anyone think the counties aren't being effective? Are all counties being ineffective? Why should the state preside over these functions rather than stakeholders? None of this has been addressed. And including, how does SB 326 pair with the bond, which if I had time, you will know that it doesn't. These laws don't speak to each other legally. This is in the minds of the administration, what the grand scheme is here. It's not in the bill language. I can't tell you, no one can tell you exactly how they work together. So again, this is from the analysis. This is the California Behavioral Health Directors Association. This is the association of all the counties that do behavioral health. They're saying, look, you're requiring us to do extremely deep cuts that are going to destabilize people and risk lives. Why are we doing this? There is no response from the administration. Racial and Ethnic Mental Health Disparities Coalition, their objections are in the analysis. And you have the staffers coming back again saying, even after the amendments, they don't resolve the concerns. Nothing is being addressed. None of the criticisms have been addressed. Concerns relating to cuts have not been addressed. This is the legislature itself saying this. It's all publicly available information. You can go grab it. Including one of the things the administration has said is like, don't worry. These other programs we're doing, primarily Medi-Cal programs, are going to backfill, like people, somehow somebody who's going to lose services is going to gain a service somewhere else. And the staffers of the health committee said there's no evidence of that. We don't know what you're talking about. MHSA funds things that Medi-Cal won't fund. This fundamentally doesn't add up. Deep service cuts are coming. Why are we doing this? And again, I would say there has been no response from the administration, which is why there is still opposition. You will see opposition to Prop 1, including people that took a middle of the road approach and said, we have concerns. We support it if it's amended. Well, it wasn't amended, so they don't support it. And you will see that happen. But again, the rest of this is really just, what happened here. You're right. It got something incredibly controversial that wasn't vetted, that the community didn't want, that the counties didn't want, that consumers didn't support, sailed through the legislature. Ask yourself how that could happen. With regards to the bond, since March, the administration said this money was for housing for veterans, housing for persons with mental health disabilities. No one opposed it. There's not anybody in the record opposing the bond because it sounded good. And, from March until July 11th, 8 hours shy of the constitutional deadline, we were told this was for voluntary unlocked infrastructure, and then it changed and it became permitted and in fact unlimited for involuntary locked infrastructure, which they need to support some other bills they've done. So this is what the bond is at the end of the day. This was amended 81 hours before the constitutional deadline to be in print to vote on it, which is 72 hours. This didn't go through any committee. This wasn't debated anywhere. This wasn't publicly available information. And because the operating subsidies for the housing interventions money in 326 are supposed to support what's in the bond according to their oral statements, they flipped what everybody had voted for in 326 or thought they voted for housing by changing the bond at literally the last possible minute that they could to be for locked infrastructure, which is the behavioral health continuum infrastructure program. Here's the legislative history. It was a spot bill. All of these were spot bills. They were dropped on the community with no notice. Many, if not all, of the legislative rules for making laws were suspended to take these through on an expedited process. The community had no opportunity to comment, analyze, or participate in this process. No one that I'm aware of who's a community-based organization or a stakeholder in this state was involved in drafting or really substantially amending any of these laws. It wasn't a regular process, and it's a bad process and a bad policy is a quote from a county from a large county who shall remain nameless to me about what happened. And I would say, if you look at the support for the bill, not one of California's 58 counties is in full-throated support. There are political reasons why people say some more support if amended. You're not seeing anybody cheering this. If you've read any of the press, it's negative. So that's where we are. And why would, SB 326 and AB 531 that don't legally speak to each other be bundled in a proposition when they were passed separately by the legislature, and they, other than roughly relating to the same population, they have nothing to do with one another. And also in order to do this, they had to purport to suspend some election laws. So, I take what you will. Obviously, we're in no position on this. And we're in no position on this because it's massive cuts to needed, unique voluntary services through the MHSA for a reason that hasn't been justified. The housing interventions money is not true housing. There's nothing legally that binds it to that. The bond's relation to this is not clear. If you can build locked infrastructure under the bond, then and use housing money in 326 for operating subsidies for those facilities, is that a trade-off that we want to do to deeply cut voluntary outpatient services? That county said it has to cut its outpatient services 65%. That was not debated. So that's and then this is just the vote. Why did this sail through when the actual opposition is substantial and almost universal, and is a good question. I'm sure I've gone way beyond my limit, but I can take some questions.
Excuse me, Claire, Hank had a few announcements to make at the end.
Okay.
And if people will hang on for a few more minutes afterwards, can you stay on for
it's fine.
Extra minutes?
Yeah.
So Hank, would you like to wrap up the official business part, the rest of the business part, and then we can see what questions, get to some of the questions if people have a few more minutes.
We have the emails of everybody who registered, and I think that all of the announcements can be put into an email along with some of the links and Claire material. So let's just leave it at that. Okay.
And Claire, would you have about 10 minutes to take some questions?
Yeah, sure.
Okay, I'll try to make them to summarize. There are a few comments about, first of all, as Jean mentioned, there are a few comments of people whose lives have been affected by family members who have mental health issues, and they have worked in this as advocates in this field, and some of them have made some comments that I don't know if you want to. I think they're mostly rhetorical, but you might, if you want to address them. Should help for adults who need help always be client driven and not family driven? I'm
sorry, can you say that again?
Oh, should help for adults who need help always be client driven and not family driven?
No, I think it should be both. Yeah. Families are super important. I know mine was for me.
And then the other one making comment about jails, and the jails are the hospitals that never say no.
Yeah.
So a couple other quick questions that may
Yeah,
have.
I will say about the jails,
Mhm.
I have worked in jails and especially Santa Clara County Jail, acute psych unit of Santa Clara County Jail. And something that people need to understand is that when the police encounter a person who's obviously seriously mentally ill and they are taking them into custody, especially on petty charges, that's a choice. There's no constitutional requirement to arrest somebody. So we're making the choice to incarcerate people who are clearly sick. And I fully agree that, you know, it is shocking what you see in jails. And we had a saying as advocates, like there's sick and then there's jail sick. This is real. And folks should not be, that should not be our response. And I have questioned for a long time, who goes to jail and who goes to a hospital? Black and brown people go to jail. And also why in the heck we would be arresting people who are so clearly unwell that it is inconceivable that they could form the criminal intent required to commit a crime. Every criminal offenses are defined by intent for the most part. So that people ending up in jail is an absolute choice. That is a choice on the part of our criminal justice system. That is a way that we are clearing people from the streets. That is something that we are intentionally doing instead of caring for people. And I don't find it remotely acceptable. And the things that happen to people in jail are unspeakable, because it is not the appropriate place for them. It's not a safe physical plant. It's not staffed appropriately. So they just stick people in solitary who are fluidly psychotic and keep them there. So yeah, I agree. The jails have to stop.
Yeah, and so the rest of the comment by this audience members was that she's had lived experience as a mother of a son with schizophrenia. Hospitalization has saved his life and allows him to live with her. She works as a family advocate with IHOT, which I'm not familiar with, and spends her days trying to connect folks with severe mental health illness to mental health services, and remarks on how unbelievably challenging it is. And families are in danger from their loved ones who are being told by the police to get a restraining order because there are not enough hospital beds to provide treatment. And her comment, jails or the hospital would never say no. So that was the background.
Yeah, and I think, you know, I mean, it's cool. I'm glad that people are commenting, because I think it's really important to have like a real conversation about the trickiest ethical issue right in front of you and really talk about it. You know, I think for us, like, yeah, we want to, I think personally, like, we have serious mental illnesses. The people that are doing this advocacy have serious mental illnesses, and we've experienced extreme states, extreme emotional states, extreme perceptual states. These things are real, and they're devastating, and they're dangerous, and how you respond to them is very important. And I think, you know, you will people run the gamut in the peer community, from folks that say, you know, there are times when it's okay for the state to intervene against someone's will, but we want to closely conscribe when those are. And we don't want everything to turn into force. And we think that if you want to be really successful with folks, the thing that sticks, the thing that works, the only thing that works is voluntary services. And our experience as people, as clients, as patients, is that the mental health system really stinks. It's just not good at dealing with us. It's not compassionate enough. It doesn't understand us. It doesn't know how to negotiate with us. It chooses to do the satisfying short-term thing, which is use force, instead of the patient long-term thing that leads to people being able to put their lives into a place of goodness, you know, for them and for their families. And I don't, you know, so I think, you know, this, like, we get characterized as like super abolitionist a lot, but we're actually pretty nuanced thinkers on this. And I think what the peer community wants to see is, we want to see the excesses of a harmful system reduced. But more than that, we want to see the alternatives built out and funded, and we'll prove to you that those work, right? Just fund it, And we'll show you that we're good at this. We'll show you that we're good at taking care of our own. But it's really sad. And I've served many Medi-Cal clients, and I think a lot of the counties do actually do a good job, but it's still not enough. But I've seen clients where, they can't, I mean, they're Medi-Cal clients and they can't even get in to see their outpatient because we have a workforce shortage, or because people are overburdened. And I've seen people just decompensate to the point where they end up in the acute end of the system because they can't access outpatient care, and not all outpatient care is competent. So, I mean, it's a complex issue, but I would say, there's many peers who will tell you that, something involuntary worked for them. And, I'm like, I will fight everyone if you try to do that to me, except that there is one time when I actually want that for myself. And that's if I become, if I go so manic and become so delusional, and it gets away from, like somehow it gets past my ability to intervene at an appropriate time, and anybody else around me. And, there's a crazy scenario where I end up, on top of a building wanting to jump off thinking I can fly. Do I want the police to lay hands on me? Heck yes, I do. So I think there's a lot of room for nuanced opinion and nuanced thought, and the way that we get to good policy is by getting all these people in the room and vehemently disagreeing with each other and hashing it out. But I think in general, for like my organization and a lot of the organizations that have been in hard opposition to a lot of the things that the governor has done, it's not because we don't understand the issues or that we completely reject any kind of state intervention ever. It's that we think it's already too harmful, and that you stink at doing the stuff that isn't harmful, and you ought to focus on that, and you'll be more successful and do less harm. That was long-winded, but. Any other questions, or are we going to call it?
Sorry.
I've
Is
got
there any
one.
limit on how many crisis residential treatment beds can be funded by Proposition 1?
I mean, crisis res is getting funded out of CSS. It's also Medi-Cal will pay for some of it. But crisis res, I mean, Medi-Cal will pay for it if you have Medi-Cal. Not everybody has Medi-Cal. And also, like, Medi-Cal has strict medical necessity rules. So, all I can tell you, I don't know the proportion of the funding, but I can tell you that all 60 beds of crisis residential in Sac County is getting funded out of CSS, and CSS is getting slashed, and we just don't know. Somebody actually has to sit down and add up all of the new mandates and the new things you're supposed to be doing and see what's left. And I don't think that anybody has really gotten that far, in part because some of the regulations about what you have to do haven't even been written by DHCS. So it's like, all we can really say at this point is half of CSS is gone. Half of the funding for CSS is gone. So if you're looking at those PEI programs, the stuff that's funded in Sac County, half of that's gone. It just can't be paid for anymore.
I know what I'm looking at when I was looking up these bills. I saw that some of the funding in 531 is supposed to go towards 10,000 new treatment beds and supportive housing units to serve 100,000 people annually. So I'm not sure whether that's a pie in the sky or what, but
well, I mean, what it ended up being at the 11th hour that we're not happy about was, I think it's 1.5 billion for VHHP. So that's the Veterans Housing and Homeless Program. That's an existing program. So it's 1.5 billion out of the 6.8 for VHHP. It's 922 million for kind of like broad eligibility. It's kind of weird how they did it. It's not even for folks that are in the target population for MHSA. It's just 922 million for people with a behavioral health challenge who meet federal definitions for homelessness or at risk of homelessness. I don't know what's up with that. I don't know why they did that. Because it's kind of a small amount of money, and it's weird. I'm not sure what's up with that. None of this was talked about, so I don't know. But then the treatment bed money, it's 4.34 billion. I think about 1.5 of that is for counties to build anything they want under BCHIP. BCHIP can build unlocked and locked. You were absolutely correct about that in your opening statement. But the reason that we don't like that is they lack the infrastructure to do involuntary locked SUD treatment, which they just also passed in Senate Bill 43. That was known the whole time. The legislature said, we don't have any infrastructure to do this, right? They need to build out the entire infrastructure to do essentially like locked mental hospitalization, except for SUD, because they just imported SUD into that entire body of law, which probably people don't know is happening. But so, you know, I mean, there's no guardrails on it, right? So I testified in committee against the amendments on 531 at like 10 o'clock at night on the last day of session and said, hey, you just made it possible for all this 4.34 billion to be used for locked infrastructure. Why are there no restrictions saying we're only going to use 100 million of it for locked infrastructure and the rest is unlocked voluntary? Like, why did what happened?
Mm-hmm.
I don't know, but I know that there's no restriction against using all of it for locked infrastructure, and they have a locked infrastructure need.
So next question, are there any mental health care provider groups or associations in California that have expressed support for Proposition 1?
That's a great question. I mean, I'm going to get in trouble for keeping it real, but it's kind of what we do. The consensus around this was very political. You got the votes in the legislature, but the feeling on the ground, the counties weren't for it. The clients weren't for it. The one hearing that Assembly Health did, the one hearing that happened because they dropped it in a spot bill, was almost 8 hours of testimony about why this is hugely problematic from the CSAC, from the counties, from community-based organizations, even from housing people that were excited there might be some housing money that they didn't have before. Everybody was like, this is a problem. And there was really no response to that. So you have to understand that's how Sacramento works, right? Like, you can manufacture political consensus that is not reflective of what people actually want. And this was, however this deal got done, it was a political deal. And whether people are going to, now that the dust has settled, because organizations mostly took the middle road because they needed to negotiate to try to save their people, right? So like a lot of people that were worried about youth mental health funding, they didn't take a straight opposed position to it because they wanted to negotiate with the administration. They thought it was a done deal. And they needed to save their people. They needed to get as much funding as possible for their people. It's just politics. I don't know what to tell you, but I can tell you on balance that people don't like it because it's clearly problematic and there's not a good justification for it. And how much opposition now arises, I got orgs contacting me every day that weren't on my radar saying, whoa, wait, no, we don't like this because we're not sure that, you know, it's not a housing bill. It's not going to solve homelessness. Why are we diverting? Why are we doing this top-down stuff? Why are we killing all these great programs that serve all these diverse populations? Why are we doing this without a sufficient justification? And why, if you want to, you know, expand outpatient services to really marginalized, dirt poor people on our streets, why would you not raise the tax on this demographic of people that just made out like bandits? So
Claire,
yeah,
this is Jean. They're about to turn us off.
Okay.
I would like to thank you and also ask you to respond to one more question for me.
Okay.
If you could. And
Sure.
that is, are the only actions we can take with regard to this is to try to not have Prop 1 pass?
I mean, yeah, you can't amend it at this point, and it's actually hugely problematic because, I mean, I don't want to get into the legal technicalities, but once they do this to MHSA, it's really hard to change it. Just put it that way, because of some technicalities. But I mean, yeah, it's in the hands of the voters. I think, I don't think it's good policy. I don't think it's a good process. I think it's super politicized because there's so much pressure over homelessness. It is probably going to pass because it takes so much to understand these issues to really understand these bills, what's in them, why people don't like them, what the impact is. It's just complicated. And who has the time or attention span for that other than the dedicated people at the League of Women Voters? So, you know, I mean, I think it probably ekes out on the ballot under the auspices of we're building, you know, it being cuddly and we're building housing for veterans. But at the end of the day, you're also deeply, deeply cutting services. And it's not good. That doesn't, that should not happen. That's just a non-starter for us. You don't cut healthcare services to some of the most marginalized people in society without an extraordinarily good reason, or probably ever. So
Claire, thank you very much for this presentation and your insight into about the Individual Mental Health Service Act, the legislative politics that went into this new Behavioral Health Service Act and the funding bill. And there were a number of comments that we didn't have time to read, but there were, as you would expect, there were people who attended who wanted to make sure that it was heard that they had circumstances where the Mental Health Service Act didn't provide what they needed for their loved ones, and they have some frustration about the act itself, and welcome some of the changes. But on that note, I really appreciate the depth you've gone into. I certainly learned a lot. I would certainly, there'll be a copy of the transcript available, and I don't know about the slides, but at least the slides. Jean's note saying thumbs up.
Yeah, I'll send the slide deck, and it would be great. You know, I think we should all get in a room and have a real conversation, because the legislature didn't let us do it all together. But you know, like, folks really are, you know, underserved, and just, I talk too much, but just like a little pin in it, you know, like the Lanterman Disability Services Act for people with IDD is an entitlement to services, not to housing. They need that, but that's $14 billion a year out of the general fund, and we get $2. So maybe we should talk about that. But you know, I fully agree that, like, it's not enough. Our services aren't enough, and any family that's not being appropriately supported needs to be heard, and we need to figure out how to support them.
Well, thank you very much. And thank you for those of you which was most of you, who stayed around for this conversation. I'm sorry, Claire, that you had so much you wanted to say at the end.
It's my fault.
Weren't able to get to it. One of the questions was, would we have someone talk who might have more positive view of Proposition 1? So we'll bring that up in our meeting. And we will invite you as well. So thank you for tonight's presentation, and especially the nitty-gritty information about the background and what is being taken away, not just the money that's being put out there. Okay, so Hank, do you want to close out, or?
Just to say goodbye and thank you for coming, and we look forward to seeing you at another healthcare interest group meeting.